to present to us because of the importance of organ donation in our hospital and also the role we play in the neurosciences ICU, frequently with patients who are organ donor eligible to donate organs. And so he's going to educate us a bit on that process today. So welcome.
Thank you. Good morning, everybody. Let me share my screen here. All right. So yes, thank you for inviting me. Again, my name is Doug. I work for Live on New York. And in my role in hospital services, I work with all the hospitals in the Mount Sinai system to support and enhance your organ and tissue donation program. So, well, I know that neurosurgery specifically doesn't have a huge role once we are kind of talking about the point of organ donation, but you have a big role before. You're dealing with these families, you're getting them to the point where they're maybe comfortable with a prognosis, and certainly talking about brain death and having these discussions. So I know I only have a few minutes, but I'm going to kind of go through these slides quickly, and certainly if you have questions, feel free to ask. So Live on New York, we are an organ procurement organization, one of 58 throughout the country. Excuse me. Our service area is the 5 boroughs, Long Island, and the lower Hudson Valley up to about Poughkeepsie. So we're responsible for evaluation of all of the organs and tissues for recovery, transplantation, as well as we have involvement with a lot of different research programs. We're also responsible for leading the organ and tissue conversations with families. So we never want anyone from the hospital to be involved. I shouldn't say be involved, but initiate these conversations. We certainly want to collaborate with you during these conversations, but it shouldn't really be anyone from the hospital leading these conversations. We also have a large aftercare program, which supports our donor families well after the date of donation. And in my role specifically, I work a lot with leadership on the development of policies and procedures within the health system. And of course, we do a lot of professional and public education. So as you already know, I'm sure there's a huge need for organ donation, about 113,000 people waiting nationally right now. 10,000 in New York and 8,000 right here in our service area. So, your family, your friends, potentially patients you're caring for. So there's a huge need for organ donation. And right now it's about an 8 to 10 year wait to get a kidney here in our service area. So a tremendously long waiting list. Many patients don't survive that long on dialysis. So we want to increase the number of donors and increase the number of organs available for transplant. So within Live on New York, we've done a number of things to try and address these shortages. Of course, pre-COVID, a lot of public education, DMV education, because that's the place where most people sign up to be organ donors, donor registration drives, all kinds of different events to get people involved and make people aware of the need. Legislative initiatives. So New York is a pretty progressive place in many ways. As far as legislation surrounding organ and tissue donation, it's pretty far behind the rest of the country. Some positive changes just in that were enacted in June of this year. So we're heading in the right direction, but we continue to work with the legislature to make laws that are more supportive of what we're trying to do. Hospital partnerships are key for us. Hospital partnerships, we depend on hospitals to make the referrals to us, to maintain and support the patients as we're evaluating them for suitability and throughout the entire process up to organ recovery. So without our hospitals supporting us throughout the whole process, we wouldn't really be able to do what we are trying to do. And we've also expanded the donor criteria. So many of the things you see here were immediate rule outs. Now we're looking at every referral made to us on a case-by-case basis. So we're never ruling someone out for age right away. The comorbid factors, diabetes, hypertension, they're no longer immediate rule outs. And infectious disease profiles, hepatitis and HIV are no longer rule outs. As far as HIV, in 2015, President Obama signed the HOPE Act, which allows for HIV positive donors to donate their organs to HIV positive recipients. So that is also something that was an immediate rule out, but now it's helping to chip away at that waiting list. And then donation after circulatory death, which we'll talk about a little bit more in a minute. So Mount Sinai has a nurse-driven referral process, which I'm sure you're probably aware of. So it doesn't fall onto the physicians at any level to make the referrals. Sometimes it does happen, but it's really a nurse-driven process. So we do a lot of nurse education to get them to recognize these clinical cues and to make that referral to us. So within 1 hour of every death that occurs in the hospital, they're required to call us for a potential tissue donation. Now, within 1 hour of mechanically vented patients meeting any of the following, so absence of 2 or more brainstem reflexes, GCS of 5 or less, or if there are family discussions where withdrawal of treatment is starting to come into play. And that bottom one, it's a bit subjective. It doesn't have to mean the family has decided to withdraw, because at that point, it's typically too late. We want to be involved in these decisions before that, so the family can consider potential donation as part of their end-of-life planning. And no call is too early, as you see at the bottom. So we want these referrals as early as possible for many reasons. Logistically, we have a very large service area. So if we're moving our transplant coordinators around, we might have someone in Poughkeepsie, someone in Long Island, and then they have to get to the city. So logistically, it's easier for us if we can get there on site to do our evaluation and either rule patients in or rule patients out. And that is the primary reason. But the earlier we're involved, there are a lot of studies out there that show the earlier the OPO is involved, the better the outcome. So higher authorization rate and more organs available for transplant. So once again, just kind of a review of the triage. So a patient dies on a unit. It doesn't matter which unit they're on. It could be any place in the hospital. The nurses or physicians could refer to us within 1 hour of death for potential tissue donation. And then for your vented patients, so ICU, ED potentially, any kind of vented unit, if they meet these clinical cues, they're referred to us within 1 hour for potential organ and tissue donation. So something that we face every day in what we do is the authorization paradox. There are all of these polls and studies out there that show that there's a huge level of support for donation. Over 90% of people polled say they support donation, but when it comes to authorizations, it's much less. So this was a study back in the late 90s, but it still really does hold true today as far as brain death. So this was a Harvard School of Public Health study, and they reached out to donor families a number of months after they were approached for donation authorization. And the first 2 questions here, the first one, my relative was brain dead. As you can see, there's not really a lot of difference between those families that authorized donation and those families that didn't authorize donation. So when we're moving into the second category here, they were asked, is a person diagnosed as brain dead, in a coma, or dead? And as you can see here, we're starting to get a little bit of a change. So 63% of those that authorized knew that their loved one was dead by brain death criteria. 45% of those that didn't authorize didn't know that. So down here at the bottom is the one that's most concerning, and that's why we really want to make sure that families have a good understanding of brain death. That's kind of one of the biggest challenges that we face in our process. So after they were given about a 10-minute crash course on brain death, all of the ins and outs, what it looks like, what it actually means, when they were asked if they would make the same choice about donation today, 94% of those families that authorized said yes. And of those families that didn't authorize, 34% said no, or they didn't know after they had a better understanding of brain death. So we understand that, when you're having these conversations with family, they're high stress, you have lots of other cases that you're dealing with. But one of our biggest challenges is getting families to really understand brain death. So if we are coming in for a potential donor and we're talking to you, we'll try to gauge your analysis of kind of the family's understanding of brain death, assuming it is a brain death donor. We really just want to make sure it's the appropriate time that we are approaching these families and that they really do understand what's actually going on. So we're working on some transitional language, which we have used before. And this is something new to us, but a lot of hospitals have been asking because they know it's not that the role of the hospital by CMS regulations, and just from a conflict of interest perspective, that organ donation shouldn't really be brought up by the hospital. So these are just some statements that have been used around the country, kind of best practice statements. So alerting the family that the testing has been completed, confirming that their loved one has died, giving the family the official date and time of death, mentioning the loved one by name, and allowing the family to take time with the family and tell them that you'll discuss more steps with them soon. So I think, These are things that most of you already do, but it's really important in what we are trying to do when we come in after you've told a family that their loved one is brain dead. Again, it's really important that they really understand that. And some other factors that do affect organ donation authorization rates. So we always want to talk to families in an appropriate setting, which is almost never an issue at Mount Sinai. You know, we can always get a conference room, a private room, something along those lines. But when you see here, 67% authorization rate when it's an appropriate setting, so off the unit, a private room, never in the patient's room, never in the hallway, just outside of the patient's room. We also want the request to be decoupled, so not at the same time you're giving those patients' families a grave prognosis or letting them know that their loved one has been declared brain dead. We need to give that family some time before we go in and talk to that family about donation. And then finally, this one speaks to collaboration. You know, we want to work with the hospital staff. There's a higher authorization rate that will come from collaborating on these discussions, but just keep in mind that it should be us leading those discussions. And these are 6 scenarios that would trigger a donation discussion. So at the top, you can see here, when brain death is pronounced and family understands, that's kind of the point we would step in and try to talk to that family. If the family mentions donation, if they're looking through someone's wallet and they see an organ donor insignia on someone's driver's license, they might bring up organ donation to you. So if we're not involved at that point, certainly give us a call or let us know if we are involved that the family did mention donation. If the family suddenly decides to limit or decelerate or withdraw therapies, which does happen, hopefully if they get to that point where they're ready to withdraw, we're already involved. But if not, certainly give us a call there too. At the bottom here, if the family understands death, the patient is not brain dead, but their illness or injury is non-survivable, we would approach that family for a donation after circulatory death pathway to donation. If donation is mentioned independently of Live on New York, so if someone from the hospital brings up donation by accident, if it comes up in conversation, you know, we often have social workers, chaplains, where donation just comes up kind of organically. It's not an ideal situation because we want to be there to give the family enough information to allow them to make an informed decision. So again, if we're not involved, call us. And then finally, if the patient is on the verge of coding, that might be a situation where we actually will talk to the family before we're sure of suitability. In all these other cases, we want to make sure the patient is fully suitable and eligible to donate at least one organ before we talk to the family. We never want to get their hopes up and then have to go back and tell them, I'm sorry, your loved one is not suitable. However, in the case of a patient coding, if we can add pressors or if we can do something to maintain or stabilize that patient to preserve the option of donation, we might talk to that family beforehand. And then this is just a statement that is kind of often used if a family does bring up donation. Just let them know that you'll have someone else come talk to them about it and try not to engage. If they continue to push, you know, you're kind of in a position where you have to talk about it, but certainly let them know that you'll have someone come talk about it and one of our social workers will come and speak to that family. So who can authorize donation? This is a list, the hierarchy of authorizing parties, and we would go down this list to find the person to authorize donation if the patient was not registered themselves. So if somebody is a registered donor, either through the DMV, through a donation registry, in any way, that's legally binding. So they made that decision when they were of sound mind, and the families cannot overturn that decision. It's legally binding. If the person is not a registered donor, we would go down this list to try to seek authorization until we get to the person that is identified as the authorizing party.
You have a 2-minute warning.
Okay, thank you. Cool quote, the care of the donor is essentially the simultaneous care of multiple recipients. So keep in mind, you know that patient that you're taking care of right there is not going to survive. However, you're taking care of a lot of other patients too, the 8 other people who could potentially survive by getting their organs, 50 plus people who could get their tissues. So you're never just taking care of that one patient who you know isn't going to survive or has already been declared brain dead. And then the program goals at Mount Sinai. So we want to, of course, increase the number of organ donors and organs transplanted, continue to provide donors and families compassionate end-of-life support. We want to increase knowledge throughout the whole system. And really just build collaboration to make it a more smooth process. And that is all I have.
Doug, thank you so much for joining us. Can I just ask a question? If you can sort of talk briefly about the differences in your processes between pediatric and adult patients who could be organ donors?
So, the process is actually much the same. I think the major deviation in process for pediatrics versus adults comes in the beginning. When we're dealing with peds, the medical team tends to be more involved. They're involved in these conversations. You're taking care of this entire family. So there's kind of more of a sense of the medical team being involved in the donation discussions and things like that. As far as the workup, the allocation, much of that is the same. There's really no significant deviation in process between pediatrics and adults, other than potential, if we're trying to maintain particular organs. Obviously, we're going to use, different methods to maintain those organs, but generally speaking, the process isn't much different.
Thank you.
Thank you.
Thank you very much.
Okay, we're going to go on to the next speaker here. My pleasure to introduce Peter, who may not need any introduction by now. But for those of you who don't know, Peter is a pediatric neurosurgeon who we came to know over the past few years as we were ramping up this program. He has the unique background of my getting the call from his fellowship director, Rich Ellenbogen, and the chair of that program actually, telling me that they tried as hard as they could to keep Peter there in Seattle. That's for the very first thing I heard about Peter, is that he's so outstanding and integrated so quickly on the other side of the country from where he trained at Cornell, and was thought so highly of that they had tried very hard to keep him. It was no surprise to me once I got to know him. He's done very well in his first period of time here at Mount Sinai, and has a lot to offer, both in terms of his clinical care, his collegiality, and also what he's able to teach us. So today he's going to talk a little bit about DRES, is that right?
About selective dorsal rhizotomy.
Okay.
Okay. So this is a topic that I chose to present on for a few reasons, one of which is that we don't hear a lot about it. The other is that it is something that I heard very little about until I made my way to fellowship. And over the last 2 years or so, I've begun to immerse myself in this community and population of patients, and found it to be both very interesting and incredibly rewarding to participate in these patients' care. So I'm going to talk a little bit about what selective dorsal rhizotomy is, what it treats, and also some potential future directions. So what is spasticity? Spasticity, for those of us neurosurgeons who don't participate in the movement disorder field quite so much, is an increased resistance to passive motion that is velocity dependent. So this can come from a number of different causes. It is typically an upper motor neuron localization of injury, but this can be caused by cerebral palsy, traumatic spinal cord or brain injury, strokes, and other neurodegenerative disorders like MS, and also has an association with things like Parkinson's. Cerebral palsy is a perinatal brain injury, so variable effects can be seen on speech, vision, audition, and cognition, but it is primarily a motor disorder that causes a variety of different movement disorders that are folded into it. We call it a symptom complex because, as I'll show on some upcoming slides, it is an incredibly variegated disease and has many different manifestations that require many different caregivers. The incidence has been decreasing in developed nations presumably because of the quality of obstetric care and perinatal care in the neonatal ICU. The motor component of CP can affect one or more limbs So it can be diplegic, meaning both lower extremities, hemiplegic, meaning both extremities on one side, quadriplegic, affecting all four extremities. There are times when it can affect only a single limb. And it has different motor types. So spastic is the most common, but there are often elements of dyskinesia, dystonia, or ataxia that are folded in that need to be untangled as we consider the different treatment options for an individual patient. A little bit on epidemiology and prevention. So in developed nations, the rate is about 1.4 per thousand births. So it's not common, but it's not uncommon. There is a presumed genetic component in about a third, but the research there is a little underdeveloped, and I hope that we'll learn quite a bit more over the coming years. 43% of patients with cerebral palsy were born preterm, and perinatal preventive measures play an important role. So these, I'm going to show another one of these too, but I really love these dot diagrams that show both the strength of evidence and the strength of recommendation in some of these systematic reviews. And this talks about some of the preventive measures for cerebral palsy. So you can see that hypothermia after a brain injury, antenatal steroids, antenatal magnesium sulfate have all been shown to be very effective. And then the rest of these many different interventions have more variable effect. And the question of worth it in the study that is portrayed here is speaking a bit to the combination of cost and efficacy. So antenatal magnesium sulfate in patients who present with preterm labor before 30 weeks, magnesium sulfate drip has been shown to be to reduce the rate of cerebral palsy and perinatal brain injury. Antenatal steroids has been shown to be effective for a wide variety of postnatal conditions, and so it's pretty much the standard of care. And hypothermia in after hypoxic events, so a child who's born with a presumed hypoxic injury, either because of apnea or low APGAR scores, can be transitioned to a hypothermic treatment pathway. And then this caffeine pre-extubation, this is more investigational, but there's been some suggestion that giving I believe methylxanthines pre-extubation for infants who've had possible brain injuries has been shown to reduce the rate of cerebral palsy later. In terms of grading cerebral palsy, we have a number of different scales, sometimes too many to work with, but some of the most useful ones I'll show here. So the gross motor function classification system essentially defines the overall, mostly ambulatory function of a child. So it grades from 1 to 5, 5 being the most severe. These are children who have minimal head control and are wheelchair bound, down to essentially a normal or near normal child who can climb stairs independently, carry objects upstairs, along with these in between. The important cutoff here, as most of our scales have, is really 2-3, is that defines the ambulatory versus the non-ambulatory child. The manual abilities classification scale speaks to upper extremity, primarily hand function in terms of handling objects either easily or unable to handle them at all, and everything in between. And then in terms of objectively grading spasticity, or as objectively as possible, similarly to grading reflexes on a 1+ to 4+ scale, we have the modified Ashworth scale that allows us to grade the individual limbs severity or individual muscle group severity of spasticity from normal muscle tone up to rigid flexion or extension. And this gives us a lot of granularity if we go muscle group by muscle group, and can significantly guide therapy, particularly when talking about rhizotomy, which I'll get to how that's true later. Quality of life indices are critical for these patients. I mentioned that this is a symptom complex, meaning it affects many, many different components of a patient's life. And so assessing what are the areas in which the patient is limited and how can we impact those areas to improve their quality of life is, in my opinion, and I think in the opinion of many CP providers, more important than just about anything else. There are, again, too many scales to keep up with, but some of the most useful ones, I've listed a number of them here. The best validated scales for these patients are the Cerebral Palsy Quality of Life Child Form, the Pediatric Evaluation of Disability Inventory, and the Assessment of Motor Process Skills. So each of these assesses different elements of the quality of life of the patient. The other that I particularly like is the CP Child survey, because it is very comprehensive and also very easy for patients and parents to complete. And each of these typically has a parent form and a child form, so that we can assess the point of view of both before making any decisions and moving forward with that family. So how do we manage spasticity as a group? So I put this up because we have a multidisciplinary clinic here that began shortly before I started here and has grown significantly. And I think it really is emblematic of what one needs to care for these patients, and something that frankly is missing in a lot of institutions. It really centers around the primary care of the patient, a complex pediatrician who handles difficult medical cases, but is surrounded then by physical therapy, occupational therapy, speech therapy, social work, child life, rehabilitation medicine. And then as we go out toward the periphery, we have the interventions from many others, whether it be neurology, orthopedics, neurosurgery, ENT and pulmonary medicine for airway management, urology for urinary management. And so each of us plays a role, a differing role depending on the patient, but we really all have to be there. In the absence of any one or several of these, you really become a non-comprehensive center, and you need to start involving other institutions or other independent providers to care for these patients. Unfortunately, here at Sinai, we have all of these, and we all sit in the same place and see the patients together. Coming back to these dot diagrams, these are some of the interventions that we have available to us for managing spasticity and motor function specifically. So divided by motor, early intervention programs, tone management, and contracture and alignment, all of which come together to affect the child's motor functional scores. We have a wide range of quality of evidence and quality of interventions that have been investigated, but some of the ones I want to draw attention to here are in these big green circles, including the many different physical therapy interventions like mobility training, treadmill training, goal-directed therapy, partial body weight support treadmill training. All of these have a huge amount of evidence and have much more significant impacts on the patient's quality of life than many of the pharmacologic and surgical interventions that we perform. Coming over to the tone management area, I want to zero in on these two: selective dorsal rhizotomy and intrathecal baclofen. There's good evidence in favor of both for certain populations and certain indications, but you can see that, again, the quality of evidence and the impact of many of these other non-surgical interventions can be bigger, and so these cannot be done in isolation. So important in all of this is setting goals and setting boundaries. What I mean by boundaries are what are we seeking to accomplish for the patient, and what are we willing to give up for it? So for example, I'm going to speak a little bit about a case at the end in which the patient had severe spasticity, but the parents were either unwilling or unready to accept the likelihood that the patient would not walk in the future. And so they were unwilling to submit to a more aggressive rhizotomy because they did not want to take away any possibility that he could walk in the future. I'll talk more about that when I get to the case. Medication adherence is huge here. These patients are often on multiple medications, whether it be for seizure control, spasticity control, or otherwise. And if they don't take them, we end up with more hospital admissions for either uncontrolled seizures or just inadequate management of the patient's spasticity, leading to consideration of surgical interventions that they may not need if in a better educated scenario where they may be able to take the medications. I discussed a little bit what we're trying to accomplish here, but really it's about improving function in some patients, but in other cases, it's not about function. It could be about pain management. It could be about simplifying care if care is too difficult because of contractures, or a wide variety of other issues, making it easier for the child to sit in a wheelchair long-term. Zeroing in on what bothers the parents the most or the patient the most and what we can do about it is critical. And that's often where these quality of life surveys come into play, and also just spending a lot of time and listening to what they have to say. The medications for spasticity, baclofen and benzodiazepines, among others, are the systemic medications that treat muscle tone. Botox can be injected into the individual muscles and has a several month time window of effect and has some good evidence to support it. Early intervention therapy is the most impactful thing that we can all provide for these patients, so sending them off to the physical therapist early. And then the surgical interventions really fall into two major categories: orthopedic, which include tendon releases, osteotomies, and scoliosis care. These are orthopedic surgeons treat the after effects of long-term spasticity. When significant spasticity causes contractures or deformities, then we need orthopedic assistance to manage them. I view the neurosurgical component here as proactive in trying to prevent these deformities and trying to enhance function. Intrathecal baclofen, rhizotomy, and complementary to the orthopedic surgeons, also scoliosis care. And I'll reiterate, because I don't think I can say this enough, that in the absence of any individual in this gigantic care team, the care is compromised. So what are our neurosurgical options? We have intrathecal baclofen, which I think every person who has put in a baclofen pump has a strong opinion, either in favor or against. I'm going to try not to present a biased version of this. I know that I favor rhizotomy in a lot of situations, but I will be the first to acknowledge that baclofen pumps have a role, and their role is important. And so we can't ignore them or marginalize them just because they are difficult. Some of the differences I've highlighted here. So baclofen pumps provide adjustable spasticity management. So you can adjust the dose at any time. You can stop the dosing, obviously with risk of withdrawal, but it is an option. Whereas SDR provides a fixed management of spasticity. So once you do the surgery, you can't reverse it. Quadriplegic is better than diplegic for intrathecal baclofen. It treats the entire spinal cord, does not treat only the lower extremities. For patients with diplegic cerebral palsy, they tend to respond better to dorsal rhizotomy because we're treating the lower extremities. Cervical dorsal rhizotomy exists, but is much less used, and in my experience, more challenging, and with higher risk of cervical deformity following. Importantly, there has been some emerging evidence that dorsal rhizotomy in the in the lumbar spine does have some impact on upper extremity spasticity for reasons that are not 100% clear. So that's an area of investigation. As I mentioned, all muscle groups are affected by baclofen, not so much by dorsal rhizotomy. There is an implanted device, which brings with it a risk of infection with intrathecal baclofen, which is lower with rhizotomy. And then in terms of age or size cutoffs, for baclofen, the patient just has to be large enough to accommodate a pump. It could be as young, in my experience, as age 3, but often a little older. And rhizotomy, most people won't perform one before the age of 4, as they want to sort of see where the child's development is headed before intervening in a non-reversible way. Some challenges I alluded to with intrathecal baclofen include infection. There's about a 5 to 10% SSI rate, which for all of the things that we do is fairly high. Compare that to the shunt infection rate, which tends to be 5% or less. Device failure, whether can cause withdrawal, which can be life-threatening. And so this is a major issue to keep an eye out for in these patients. I mentioned that it isn't targeted. So if you're trying to do something for one muscle group, you're not going to achieve it with baclofen. It's going to treat the whole spinal cord. And lastly, the physical impact, the abdominal site, pain, discomfort. It's a large pump. It's often uncomfortable to sit in certain positions for patients. So I take that into account and counsel families about that as well. So on to rhizotomy. The history of rhizotomy is fairly long. It goes back all the way to the first rhizotomy for pain in the 1880s, and then for the management of spasticity began in the early 1900s with non-selective dorsal rhizotomy, with the underlying theory being that decreasing type 1A sensory input to alpha motor neurons in the reflex arc would reduce the output, the excitatory output of these alpha motor neurons and decrease spasticity. In the 1970s, this became a selective procedure pioneered by Fasano, including sectioning rootlets that were innervating specific muscle groups. And then Peacock really pioneered the use of intraoperative stimulation of these selected rootlets, the technique for which we still use today, in order to grade and then determine which rootlets are most contributing to spastic tone. So the indications for SDR have been about the same for a while and are now starting to evolve. So there is class 1 evidence supporting the treatment of ambulatory children, and I'll go over that evidence shortly. who can benefit from surgery? So what are our goals? In the ambulatory child, it is making them more independent. In the non-ambulatory child, it is helping them sit up in their wheelchair, giving them better truncal control, perhaps decreasing pain, improving perineal care. So patients with scissoring deformities of their legs, it's very difficult for parents to change their diapers. And this can actually help in that endeavor. Diplegic versus quadriplegic I mentioned, so I won't spend any more time on that. Important here is untangling the other motor disorders in a spastic patient. So frequently these have complicating dystonia, chorioathetosis, ataxia in the ambulatory child, and figuring out what's most contributing to their decrease in function is important. If they have a large component of these other motor disorders, you will not treat it effectively with SDR and you may make them worse. Relative contraindications. So I mentioned a few of them here in the other motor disorder category, but limited motor strength or truncal control is a relative contraindication for a child who is ambulatory. So if we're looking to improve their function, but their spasticity is assisting their truncal control, they need to go through a pretty significant preoperative regimen of strengthening before undergoing rhizotomy so that we don't just make them floppy without good muscle control postoperatively. So that's an important consideration, and one of the reasons that most of these patients are referred really early to more therapy prior to surgery. Severe spinal deformities can make the procedure more difficult, and in some cases can be worsened by some of the ways we do this procedure, which I'll show next. And then basal ganglia or abnormalities, periventricular leukoencephalomalacia or hydrocephalus on imaging has been shown to represent populations who are less likely to benefit from rhizotomy, but not completely unlikely. So it really depends on the goals of surgery. The electrophysiologic monitoring here is very interesting and not really anything like what we do in the rest of the spinal cord. So with EMG monitoring and a very experienced electrophysiologist, we use a pair of hooks, anode and cathode hooks, to pick up each nerve root in the cauda equina. Test for a threshold between dorsal and ventral by delivering a brief stimulus to each root. And once we've established that, then a 1 second stimulus, 50 hertz trained stimulus is delivered to that nerve. And then we grade the response. Grade 0 is a normal response where you would expect the associated muscle group to activate. A sustained response at the stimulus level is a tetanic response, which is abnormal, but not grossly so. Adjacent level activation raises you to grade 2. Ipsilateral spread greater than 1 level is grade 3, and then contralateral spread is grossly abnormal and is graded 4+. And this helps me and anyone else who does this procedure determine which roots to cut and how much to cut. And some of that remains subjective. There isn't good evidence to say cut 50% of the roots that are grade 3 and 75% of the roots that are grade 4. And really clinical experience guides that decision at the moment, although I'm attempting to collect data on all these patients that will help us help give a little more guidance that's more granular there. Avoiding sphincter-related complications is important, so using the electrophysiologic monitoring of the anal sphincter to identify those rootlets and preserve them is really important, and also not cutting the phylum is very important here. We're doing this procedure just below the conus, and the phylum at the level of the conus, there is not clarity between the end of the conus and the beginning of the phylum, and so you could cut some important centers there if you cut too high. Gross abnormalities are widespread in the electrophysiologic monitoring of patients with CP, so we see really abnormal responses in patients with severe or even mild cerebral palsy, and so it's sometimes difficult to sort through all of that. And then just very briefly, there is some consideration of moving to doing the dorsal and ventral rhizotomy for the patients with severe spasticity, since they are not so dependent on the motor function in their legs to ambulate. But in cutting some of those ventral roots as well, we can more effectively accomplish our goals of surgery, which is improving care and decreasing pain. The surgical approach and technique has evolved over the years. So Peacock's original technique involved a long laminectomy, but that has evolved to these other sort of less invasive approaches, including keyhole laminotomies, single or two-level laminectomies or laminoplasties at the level of the conus or below. I do a 1 to 1.5 level laminectomy just below the conus typically. The risks of SDR are similar to most intradural operations. CSF leak, surgical site infection. Secondary kyphosis and scoliosis has been dramatically reduced with these less invasive techniques. So you can imagine a 4 or 5 level laminectomy in the lumbar spine in a child can lead to significantly increased spinal deformity down the road, but we've managed to minimize that over the years. Urinary dysfunction typically comes from being overly aggressive at sectioning sphincter-related routes. And then over-treatment of spasticity. This is a more of a theoretical. Patients are afraid of this, and certain providers are afraid of this and often won't refer for rhizotomy because of it. But it is infrequently seen and typically overcome by good physical therapy. So the evidence for ambulators here, dorsal rhizotomy plus PT versus PT alone. There have been 2 trials. Both showed a significant improvement in Ashworth scale measured spasticity in the lower extremities, and the gross motor functional classification measure improved in one of these trials. There was more back pain in the SDR group, but minimal additional complications, so it was a safe procedure. And then in comparing SDR to Botox, Botox showed a much more rapid improvement as expected, which was lost over time as the Botox effect wore off. But the initial deterioration with SDR improves over 6 to 20 months post-op and has a more durable improvement and effect. So this is all for ambulatory grade 2, grade 3 GMFCS spasticity. But in choosing patients, we need to consider some of these other patient populations as our treatment has evolved and as our considerations of what we can do for them has evolved. So severe CP is an emerging area where dorsal rhizotomy has been useful. Patients with severe spasticity who have significant orthopedic complications, hip deformities requiring osteotomies, Achilles tendon, or other tendinous contraction requiring releases, simplifying their care, reducing their pain. We need more evidence for this. There are no randomized controlled trials, but there is an increasing class 3 body of evidence that is supporting this, and we are attempting to have more sort of prospective, registry-driven evidence in favor of this. Post-traumatic is also an emerging area. This is much smaller, mostly small case series, but is a really exciting area where we can potentially zero in on individual muscle groups after spinal cord injury and improve the function of these patients as our rehabilitation interventions improve too. And this is where people like, David Petrino's group really come into play as we have a multi-pronged effort to improve the lives of these patients. So I'm going to talk about this case last and leave a few minutes for questions. This was a 6-year-old boy who had GMFCS5 spastic quadriplegic cerebral palsy with neuronal migration disorder and seizures that were under good control. And he had a number of prior orthopedic surgeries. He'd had bilateral lower extremity tendon releases of the hip adductors and Achilles, pelvic osteotomies for dislocations, bilateral iliopsoas lengthening procedures. And he was still, despite all of this, having increased scissoring of his legs, difficulty with perineal care, equinovarus foot deformities that his grandparents were very focused on and very concerned about, and pain with every form of passive motion. This was a kid who every time I saw him was grimacing when I touched him, and it was very difficult for everyone to manage. And he frankly was miserable, and so were his caregivers. And so what we did for him, we suggested a rhizotomy for a few reasons. One was that baclofen didn't work well for him. Systemic baclofen didn't work for him. And his family also was did not like medications. So they didn't like the idea of going through a number of other medication trials. They were afraid of side effects, and they were never going to adhere to a medication regimen that we recommended. And so we essentially gave up on that approach. We considered baclofen pump, but this was another problem that, these children frequently have tics or other behavioral issues related to either scratching incisions or picking at incisions. And that's one of the things that increases the infection rate. And also the family didn't want to implant anything if they could avoid it. And their primary concern, importantly here, was the legs, scissoring of the legs and the foot deformities, which we could address with rhizotomy. So the way I like to do this procedure I mentioned is with a 1 to 1.5 level laminectomy. This is cranial is on the left here, caudal is on the right. And this is all of the cauda nerve roots. And I take essentially a background and wrap it around all of the cauda nerve roots, suture it to the dura, and then pick up these roots one at a time with these two hooks, the anode and cathode hooks, and we give our stimuli, and then we talk about what the response is, and then decide how much dissection. It's a slow procedure, and takes typically, once we get started, 3, maybe 4 hours. And we have to work through all of these roots, and there were about 100 plus rootlets that we had to do this for over the course of the procedure. And after each one, I tuck the root behind the other end of the background that's not sutured, so that I know that it's been treated and we can move on to the next. And this is at the end. We're on our last root. You can see the background is out because everything else has been addressed. In this process, I try to go back and forth so that the whole cauda doesn't get rotated and make it increasingly difficult to pick up roots. So that's a nuance to the procedure that's important to remember. And then at the very end, we pick up the exiting L2 roots, which are right up here at the top under the dura. So we angle the scope up and get the dorsal roots of L2, and then close in a typical fashion. So this patient did extremely well. He came back into the office 2 weeks later and then 6 weeks later, smiling, much looser. The scissoring deformity was gone. His family was thrilled, and he now 3 months post-op is continuing to do really well. And my hope is that with ongoing physical therapy, we can even improve his function a little bit and his motor control so he can sit better in his wheelchair without being reclined. So a few conclusions here. SDR, I glossed over this, but it is clearly a safe surgical option. The rate of surgical complications is extremely low when compared with other interventions. The best evidence, as I mentioned, is for GMFCS grade 1 through 3 cerebral palsy, the ambulators, but there is emerging evidence for the grade 4s and 5s, as well as for spinal cord injury or traumatic brain injury. And this is a hugely impactful effort for quality of life. You know, on the surgical side, I liken this to our increasing involvement in other areas, such as movement disorders, psychiatric disorders, neuromodulation for epilepsy, neurointervention for stroke. We have begun to look beyond what are traditionally neurosurgical conditions so that we can help patients with the tools that we can provide as part of these much larger care teams. This is an incredibly grateful and needy patient population. They are frequently marginalized, and are always looking for a friendly face that can provide assistance. So thank you for the opportunity to present today, and I'm happy to entertain any questions or comments.
Thanks, Dr. Morgenstern. It's Alex. Thank you so much for the talk. It's really interesting procedure that I hope that we'll be able to do more here going forward. Just had a question of the relation between this procedure and deformity correction. Obviously, a lot of these cerebral palsy kids will go on to need some type of correction, whether they're independently ambulating or just for truncal stability to stay in their chair. What do you think the ideal relationship is between planning their deformity correction with dorsal rhizotomy? Do you think one needs to go before the other, or they can be done more in a conjunction type fashion?
So most patients with CP don't need a deformity correction, but the ones who do are definitely more complicated. It's a good question. In most cases, I would suggest doing the rhizotomy first, partly because it is complicated by the presence of spinal hardware, but also because you will see the eventual impact of the rhizotomy on muscle tone, truncal control, and progressive deformity over the weeks and months post-op, and then you can progress to a more thoughtful deformity correction with all the information in hand.
Thank you.
Hey, Peter, great talk. Really enjoyed that. Thank you. I had a question for you. So I think for the diplegic patients, it's clear that SDR is really a great procedure. For the quadriplegic patients, though, do you think that a trial of intrathecal baclofen is worthwhile up front in those patients just to see if their arms could get better?
I do. So I actually really like using baclofen pump trials before putting in a pump. They're so easy to do, and they give you a good indication of how it's going to work. The only thing that's not so great about a baclofen trial is that it is a whopping dose of baclofen, and it's not typically at the doses that you would give through the pump. But you're right. A lot of it comes down to what the concerns are. So if their upper extremity spasticity is not so severe and it's not affecting their quality of life, then that isn't necessarily the thing to intervene on. I think the jury is still out as to how lumbar dorsal rhizotomy affects upper extremity tone. It clearly does for reasons that are not well understood, and it doesn't necessarily affect it in all patients. But I've seen it a handful of times where their tone is better in their upper extremities after lumbar dorsal rhizotomy. And I frankly can't explain the neurophysiology of it.
Really interesting presentation, Dr. Morgenstern. I was wondering, when you're doing the rhizotomy, you use the cathode and anode electrodes. When we're doing cord detetherings, we similarly use neuromonitoring and stimulate nerve rootlets, but with just one single electrode. Is there a reason you have to use a cathode and an anode?
So that's a question that's probably better answered by either Svetlana or Nestor, but I believe it has to do with the delivery of the stimulus train that we're giving. It's not just a single milliampere stimulus that we're using to threshold for other monopolar stimulation in the cauda. But I'll get back to you on that one.
Hi, Dr. Morgenstern, it's Trevor. Just had a quick question. So I know when we were doing the procedure that you described, a lot of our cuts were around 50%, and there was a lot of, as you said, some subjective percentages that we would try to achieve. Is there any literature on patients getting a second procedure to achieve, cut more of each of those nerve rootlets and go back if they don't achieve the desired result?
So there isn't. I know that some of my colleagues have experience with this. The most experienced person in the country providing rhizotomy at the moment is T.S. Park at WashU St. Louis, who's done several thousand in his career. And I know that there are a number out there who've done many who have had some recurrences, but they really haven't published a great deal about them. I know it's possible to go back. I would rather be, if I'm at a point where I'm unsure of how aggressive to be intraoperatively, I'd always rather leave it for another time. But as a general matter, I think that once you've done the procedure and you move on to the PT, it's infrequent to have to come back.
Thank you.
I had one more question if we have time. Just going off Dr. Hadjipanayas's question, what do you use as a paradigm in terms of who you want to trial baclofen on versus who you just jump right to selective dorsal rhizotomy? Like, is there a certain algorithm you use, or do you give a baclofen trial to the majority of these patients that you evaluate?
It's really a discussion with the family about what we're trying to accomplish. If it's primarily lower extremity, then I favor rhizotomy in most situations. If they want something that's reversible or modulatable, then we head towards the baclofen. Or if we want to treat all four extremities, we certainly lean in favor of baclofen. The other thing about baclofen is if they're taking systemic baclofen and it's been working well for them, but they're requiring increasingly high doses, baclofen has pretty poor CSF penetration when given systemically. So for those patients, if they like the effect of the baclofen, then you can optimize it with a pump. And so that's useful.
Dr. Morgenstern, in terms of the post-traumatic population, is this, a couple of questions, is this really more in an investigative stage, or are neurotraumatologists systematically considering this in the care pathway? And my other thought here is physiatry sort of the typical referral pathway to use an intervention like this in a trauma patient? Yeah,
so I think typically for all of these patients, it's a combination of rehab and their primary care providers and maybe neurology. The trauma side is definitely a more investigational area, although there are several hundred reported cases out there and it's gaining acceptance. But yeah, I would consider it to be not the standard of care, but something that can be effective with minimal downside.
Thank you.
Great. Thanks, everyone.
Thanks very much, Peter. And next, we're going to have Cappi Lay talking about neurocritical care cases and pearls. Cappi, you should be able to share your screen.
Can you hear me now?
Yes, we can. Yeah.
Okay, great. Sorry about that. Let's just see. I got to share my screen here. Let's see, share screen. All right. Can you see the slideshow?
Yes, we can. Well,
Okay,
no.
great.
There we go.
Okay, great. So I wanted to talk about mechanical ventilation today. You know, just continuing the critical care Pearls series. You know, this is a topic that's frequently intimidating to people that don't do it on a daily basis. But I think you know, especially with the COVID epidemic occurring, we've had sort of an increase in the desire to understand mechanical ventilation a little better. And it's really foundational to sort of what we do in the ICU. So in terms of the goals of this presentation, you know, there's a practical element in just sort of familiarizing yourself with the Puritan Bennett 840, so which is the vent that we use most of the time. You know, there's a lot of buttons and knobs on it, so we'll try to go over some of that and get you used to the display. Again, this is sort of an introductory lecture, so we'll try to go over the basic phases of mechanical ventilation. And then I'd like you to come away with understanding really the relationship of plateau pressures to pulmonary compliance. And then hopefully, if you know, we'll do another session next time when we have more time and look at the common forms of ventilator desynchrony, which I think is sort of the next stage. So, you know, just looking at the basic objectives with mechanical ventilation. You know, we're oxygenation, obviously, ventilation, and then very importantly, you know, safety, I mean, preventing lung injury, because the ventilator has the potential to harm our patients. And we have to understand, you know, when we are risking harm and how to adjust to mitigate that. And then finally, patient comfort. Oftentimes people try to sedate patients immediately when they see there's some ventilator desynchrony or if the patient looks like they're bucking the vent. And one of the goals of understanding mechanical ventilation is to be able to adjust the ventilator to make the patient more comfortable without always requiring sedation, because there are obviously downsides to sedating the patient in terms of hemodynamics and then losing your neurologic exam. So first, I want to just go over, you know, this is the ventilator that we have most commonly in the ICU. And as you can see, there's a lot of data and numbers on the screen, and it can be a little intimidating at first. So the first thing I like to tell people is that separate the panel into, there's two halves of this screen. The bottom half is what I call the settings panel. And this is what you want to happen to the patient. And we'll go over some of the precise, you know, the variables there, but just the bottom half is the settings panel. And then on the top half, this is the monitoring panel. So this is what's actually happening to the patient. And sometimes when what you set is actually not what's happening. So you have to be able to look at both halves and make sure that you're getting what you want. If we look at, if you can see my mouse, can you see my mouse on the screen here?
Yep.
Okay, great. So these blue panels here are the sort of variables. And so when you want to make an adjustment, you hit the variable and then you go to this dial and dial it in whichever direction you want and then hit the accept button. So a closer look at the two panels, again, gives you those blue panels that we are in terms of the variables. And then up here at the top line, we have what's happening numerically. So we have our peak and mean pressures, the amount of PEEP the patient has, the inspiratory-expiratory ratio, the actual frequency or respiratory rate that the patient's breathing, which may differ from what you've set, the tidal volume that the patient's getting, which again may differ, and then the total minute ventilation. We have two waveforms here, outputs that you're allowed to see. And you're going to be able to select the type of waveform that you want based on, you know, what you want to monitor. So for a patient who's in volume control, when you're setting the volume, then you want the independent variables to be displayed. So you want the pressure waveform to be displayed. And we always like the flow waveform to be displayed. If you were to switch this to a pressure control setting where you control the pressure, well, then looking at the pressure waveform is not as valuable. We switch this to the volume waveform that we would follow. So there are four basic phases to mechanical breathing. There's the initiation or trigger phase, the control phase, what we call cycling, and then the expiratory phase. And so it's good to think about mechanical ventilation in terms of those four phases. In terms of the initiation or trigger, there's various ways to trigger the ventilator, to signal to the ventilator that a breath is needed. So if respiration is fully controlled, that trigger is just time. Right. So if you set, you know, when there's no patient trigger involved and you set a rate of 12, well, then every 5 seconds, the ventilator will just give a breath. However, modern ventilators can synchronize the breath to the patient effort, and that's advantageous in terms of ventilator synchrony with the patient. And it can be made to synchronize it to a flow trigger or a pressure trigger. What you'll see on our panel here is that flow, the type of trigger can be chosen down here, and then the degree or the threshold for the trigger is in this box. So whenever you see a V with a dot above it, that does not refer to a volume. V with a dot above it refers to a flow. So what we can see here is we're set with a flow trigger of 3 liters per minute. So when the machine detects an inspiration of 3 liters per minute, it will consider that a patient effort and will then fire the rest of the breath. Moving on to the control phase. So once the machine knows that a breath needs to be started, the ventilator will maintain either a pressure or a flow until inspiration ends. And whether it maintains a pressure or flow depends on the mode of ventilation you're in. We use assist control volume control most commonly. And in this mode, the device is maintaining a flow. That flow is set by the operator. There's also the flow pattern. And the flow pattern has 2 options. You can either set a constant flow pattern or what's called a descending ramp pattern. And we'll look at that just so you can get used to the waveforms and what the implications are for each. So looking at a assist control mode here, in a constant flow pattern, the flow pattern looks like a square wave. So once the ventilator is triggered, the flow comes up to the preset amount, and it continues at that amount through the duration of the breath until the total tidal volume has been delivered, and then expiration ensues. The descending ramp flow pattern, it just kind of, the flow goes up to a maximum and then decays over the delivery of the breath. And the advantages to that is that it tends to increase mean alveolar pressures with reduced peak inspiratory pressures. Again, overall, all other things being equal, you have more impact on venous return in a descending ramp flow pattern. And all other things being equal, you have longer inspiratory time because the flow is not as fast near the end of the breath. So it takes a little bit longer to get the volume in. Now, theoretically, there can be better distribution of ventilation into more compliant alveoli due to the slower flow rates. And so that's the theoretical advantage, although there's not strong evidence to this. It's also, as we will see, more like mimics the natural flow pattern of a breath, and sometimes maybe is tolerated better by the patient. So in a pressure control mode, we're not maintaining a flow. The machine just maintains a preset airway pressure, whatever we're setting, for the amount of time that we set it. And this results in a flow pattern that naturally resembles a descending ramp. So if we look at a similar diagram here, in this case, the pressure up here is maintained constant throughout the breath, and the natural flow pattern that results is a descending ramp. So we're not setting the flow pattern in pressure control. This is just the natural outcome of maintaining a constant pressure. So the next question is sort of, once the ventilator initiates the breath, how does it know when to stop delivering gas? So this is what we talk about when we talk about cycling. And so cycling determines the end of inspiration and the start of expiration. So you set a specific flow, pressure, or preset time to govern cycling the breath off. So let's look at some examples of that. So the first example is a time cycled breath. And this is a patient who's in volume control. You can imagine a set tidal volume of 500 cc's. They have a respiratory rate set at 12 per minute and a flow of 60 liters per minute, which is equal to 1 liter per second. So in this setting, each respiratory cycle from inspiration to full expiration takes 5 seconds because you have 12 breaths divided in 60 seconds. At this flow rate, the tidal volume is delivered over half a second because you're giving 500 cc's and you're delivering 1 liter per second. So it's half a second to get the tidal volume in, which means that the remainder of the time, 4.5 seconds, is left for expiration. Your implicit inspiration time here is 0.5, although you're setting a flow and not an actual I time. In pressure control, this is another time cycled breath, where now you set an inspiratory pressure, and instead of setting a flow, you actually set the inspiratory time itself. In this case, we're going to set it at 1 second. So again, each respiratory cycle takes 5 seconds because we're a respiratory rate of 12. And so the IE ratio is 1 to 4 because you have I time of 1 second and 4 seconds to expire. So as a note, however, remember with a set rate of 12, each respiratory cycle takes 5 seconds. However, you are setting the minimum minute ventilation by choosing a respiratory rate of 12. The patient can still overbreathe the vent. And if the patient's natural rate is 24, the ventilator will deliver the full control breath 24 times per minute. Okay, so this cuts the respiratory cycle time to 2.5 seconds without changing the inspiratory time, unless you change the flow or the I time. So that's just something you have to be paying attention to, especially at very high respiratory rates. Finally, there's also flow cycled breaths. And oftentimes we are using the mode of pressure support, especially when we're weaning or for patient comfort. And this is a mode where we do not guarantee a minute ventilation. And the trigger is the same, either a flow or pressure trigger. We give some support that the machine turns on once the trigger is identified. And then the question is, how long does the machine deliver the pressure? And we have what's called an expiratory sensitivity. And what this is it is the percent of maximum flow at which the ventilator decides to turn off. So let's look at what that, if you have a higher expiratory sensitivity, that will result in shorter breaths. And a lower expiratory sensitivity results in longer breaths. So here on the left, you have an expiratory sensitivity of 25%, which means that at 25% of the maximum flow, the machine stops giving pressure support. If you raise it to 50%, then at 50% of max flow, the machine stops, so the breath is much shorter. So let's move on to expiration. So in expiration, really, we're talking about the setting of positive end expiratory pressure, or PEEP. So the concept being that you want to maintain, you want to kind of stent open the alveoli past this natural lower inflection point here to prevent alveolar collapse. We want the PEEP to be set such that and PEEP is used to sort of maintain oxygenation and prevent alveolar collapse. Obviously, if you set the PEEP too high, you can cause overdistension. And so we don't want to go too high, but we want the PEEP to be above this lower inflection point. In the setting of edema or inflammation, oftentimes we need to increase the PEEP to counterbalance the effect of increased lung mass. And so you may have to use higher levels of PEEP to maintain or restore oxygenation. Now, when we look at PEEP and FiO2, which are the two sort of adjustments we make to improve oxygenation in patients, we see that this is a typical PEEP PEEP FiO2 ladder. And what we want to note here is that you never should be on 100% FiO2 and 5% of PEEP, right? We want to kind of ramp up or ratchet both of these settings up together, so that if we start having to go up on the FiO2, typically we want to increase the PEEP in parallel. And obviously you also wouldn't want to be on 15 of PEEP and 30% of FiO2. So this prevents oxygen toxicity, and especially in lung injury, higher levels of PEEP have been shown to be advantageous. Now, in terms of the hemodynamic effects of PEEP, I think oftentimes it's thought that PEEP reduces preload, which can be true, but I don't think it's as it's not as simple as just increasing the PEEP is going to decrease the cardiac output. PEEP also affects, as we said, systemic venous return, but it also affects right ventricular output and left ventricular filling. So I think it's good to sort of see how that works. As you recruit alveoli, remember, you're going to increase regional oxygen tension. And what that does is it reduces hypoxic pulmonary vasoconstriction and thus decreases pulmonary vascular resistance. So when you decrease pulmonary vascular resistance, you actually increase the RV output. So you can think of the PEEP as affecting the pulmonary vascular resistance in sort of this bimodal fashion. As you increase PEEP initially, it tends and improve oxygenation. It tends to reduce pulmonary vascular resistance. But as you exceed functional residual capacity, you start to compress arteries and it starts to increase the PVR. So basically there's a sort of U-shaped curve that at low lung volumes, pulmonary vascular resistance is high due to pulmonary vasoconstriction. As you start to stent open the alveoli, you get reflexive vasodilatation and a decrease in pulmonary vascular resistance. And then ultimately, as you over-distend, you start to compress again, and that increases pulmonary vascular resistance and decreases right ventricular function, performance again. So let's look at a couple common ventilator modes. The most common that we use are these mandatory ventilation modes, also known as assist control modes. And these are modes in which you are guaranteeing a minimum minute ventilation. I think that's how you can think of them, as opposed to the spontaneous modes where you do not guarantee a minimum minute ventilation. So the two most common are volume control and pressure control. And then we have pressure support as our spontaneous mode. So in assist control, volume control, we're setting a tidal volume and an inspiratory flow. Those are sort of the unique settings for volume control. You're also setting a respiratory rate, a PEEP, an FiO2, and a trigger, of course. The independent variable in volume control is the airway pressure. So that's what you're not controlling directly, but you need to make sure you're monitoring it. So again, looking at the control panel here, if we set a rate of 14 and tidal volume of 750, right? And in this case, what we see is this is a nice normal pressure waveform. We have a descending ramp flow pattern that we're seeing here. And then up here, you can look at your peak pressures and your mean airway pressures, as well as the minute ventilation and the tidal volume that's being generated in this case. Now, as we switch to a square wave, and we'll explain why we did this in a second, you see that the pressure becomes a little bit sharper. And then over here, we did what's called an inspiratory hold maneuver. And this is an important maneuver to determine what's called the plateau pressure. And you see that you in this pressure, in this one breath here, you see that a little plateau develops, and we're able to, right above it here, PPL, you see a numerical readout that gives you the plateau pressure, and we'll talk a little bit more about that. So that's kind of your normal pressure waveform, and there's your plateau wave. So in pressure control, we're setting an inspiratory pressure and an I time, as well as the other variables that we typically set with other assist control modes. And in this case, the independent variables, tidal volume and the flow rate. And it's really the ability for the patient to control their own flow rate in pressure control that sometimes results in improved ventilator synchrony in this mode for some patients. And so, you know, we can go back and forth. No mode has been shown to be superior in terms of any, you know, quantifiable outcome, but depending on what the patient's doing, we may choose pressure control sometimes. You know, again, in this case, with pressure control, you lose control of the tidal volume, so you have to be paying close attention to the tidal volume, which can lead to either volutrauma if your tidal volumes are too large, or if you're not generating sufficient tidal volume, hypoventilation. So kind of at the last part of this talk, I just want to really go over this you know, idea of plateau pressures. So first, you have to think about what the work of breathing that the machine is doing. So the respiratory work is going to be the change in pressure times the change in volume. And we can resolve the change in pressure that the ventilator creates to two components. And this is really a fundamental concept, that there are two components of the pressure change. One that's used to generate elastic work, or an elastic component, and that is the change in volume over the lung compliance. And you add that to a resistive component, or the work that it takes to get the pressure drop that it takes to get the air into the lung. And that is calculated by multiplying the flow rate times the airway resistance. So we take that equation, and if we want to actually measure the airway pressure at the end of the ET tube, then we just add the PEEP. So we have the change in pressure plus the PEEP gives you that airway pressure. Now, when flow is 0, we eliminate the resistive pressure drop change, and that gives us our plateau pressure. And the plateau pressure is used to really reflect the lung compliance and the stress on the lung that we are, you know, administering with each breath. So the key here is that you need to hold flow to 0 in order to calculate the plateau or measure the plateau pressure. So let's look at it a little bit more closely. On the y-axis, we have pressure. X-axis is time. Initially, when the breath is initiated, the pressure rises to a peak. And then as we hold flow at 0, the pressure remaining in the lung kind of gives us this plateau pressure. You can think of the difference between the plateau and the peak as reflecting the airway resistance, and the pressure from the plateau to PEEP as reflecting the amount of pressure change it took to distend the lung, irrespective of, not counting the airway resistance. And that's really what we think of as being, applied to creating lung stress. That pressure has a term called the driving pressure that it's important to recognize. And so again, that's the difference between the plateau and the PEEP. So in different situations, you can imagine that the peak pressure might be high. In this diagram, the peak pressure is high because there's high airway resistance. So when we, you see a high peak pressure, and when we hold flow at 0, the plateau kind of takes on a normal value. And this is, on the right, you see a pressure waveform in a patient with normal airway resistance. Again, normal peak pressures are about less than 40, and normal plateaus, or what has been shown to be have a mortality benefit in the ARDSNet trial, is keeping plateau pressures less than 30. In contrast, in this example, you see that when the peak pressures are high, but they're not high for the same reason. So rather than airway resistance being the problem, the reason why peak pressures are high in this case is because the lung compliance is very poor, and the distending pressures needed to get the lung open is high. The airway resistance is not the problem. So when the plateau pressure is elevated, there are two options to deal with it. And those two options are, you can lower the PEEP or you can lower the tidal volume. Either one will lower the plateau pressure, but they have different effects on the patient, right? So sometimes you may need the PEEP to remain high if you're having problems with oxygenation. Lowering the tidal volume may cause you the PCO2 to rise. You may have to deal with a respiratory acidosis, or the patient may be very uncomfortable because of the shallow breaths. So, I know this is a brief introduction. In terms of modern ventilator management, it really requires the provider to be familiar with the basic settings and monitoring panels on the device they're using. The work of breathing is separated into elastic and resistive components, and it is the elastic component that is most important regarding ventilator-induced lung injury. And then finally, the plateau pressure reflects the compliance of the lung and stress, and you want to keep that plateau less than 30. So hopefully I can do another talk with you guys and move on to ventilator desynchrony and do some cases next time. Are there any questions?
Great review, Cappi. Let's give the residents a second here to see if there are any questions. Okay, very comprehensive. Thank you, Cappi.
All right. Thank you,
everybody. Bye-bye.